Hello, how are you? Like an extension to charge my phone.
You want to plug that in?
Wants to charge his phone?
Should just plug an outlet. Be one. Yeah. Right
Oh, there it is. Perfect. Okay, yeah, that's been.
Let me make sure it's turned on.
Oh, right. Oh, this thing. Okay, good.
Good afternoon, everyone. I'm Susan Bass-Levin, and I am the President and CEO of the Cooper Foundation, and I would like to welcome all of you here today. This program is being recorded, and we will have it available on both the hospital and the medical school websites, so you can tell your friends and colleagues afterwards. They can take a look at it as well. And we are also live streaming this event, so I want to say hello to Ed and Barbara Berkowitz, who are watching this from home. Ed and I met about 3.5 years ago. I went to his home, and we talked about his vision and his dream for providing an opportunity for medical students, physicians, nurses, people involved in the medical profession to take some time to think about the human side of medicine, to think about medical ethics, how patients and their caregivers interact, what physicians think about as they're giving care. And he very generously made a donation to the Cooper Foundation to support an annual lecture series on questions of medical ethics. We are so appreciative of your support, Ed and Barbara, and to the Berkowitz family. On behalf of everyone at the medical school and here at Cooper University Healthcare, I want to say thank you so very much for your spirit, for your generosity, for your commitment to the future of medicine. So let's give a really loud round of applause and thank you to Ed and Barbara and their family. I'd like to ask Julie Berkowitz, one of Ed and Barbara's granddaughters, to come up here and share a few words on behalf of the family. Thanks, Julie.
Hello. Thank you, Susan. I also want to say hello to my grandparents. So on behalf of the Berkowitz Family Foundation, we're very pleased to continue our support of the Cooper Health System and its medical school with today's speaker, Dr. Baron Lerner. And my grandfather, Ed Berkowitz, is very passionate about healthcare, future practitioners, and the focus of humanism in that training. So we hope that today's speaker will further inspire that mission. Thank you.
Your programs have a short bio about Ed Berkowitz, and what I do want to say is Ed has been a very successful businessman, building a business here in South Jersey that actually did business all over the world. Some of the windows that you see in various places around our campus were actually manufactured there. But even more than that, he is a true philanthropist, giving support to programs, to projects that matter. And for years to come and generations to come, his support here will make a difference. To our medical students, I hope you come back to this annual lecture when you're residents and fellows and practicing physicians. And I know that you will take the lessons learned from these lectures, and your patients, our patients, will be better for it. I'd now like to call upon the Dean of our medical school, Dean Paul Katz, who will share a few words and introduce our fascinating speaker, Dr. Baron Lerner. Thank you, everyone.
Well, Susan, thank you so much. And before introducing our speaker, I want to recognize a few people. First of all, additional thanks to the Berkowitz family. And we miss Ed and Barbara being here. They've been here at the last two, and we're very glad that you're able to join us. And Julie and other members of the family, thank you so much for being here. The Berkowitz Foundation and family could have given money for a lot of different things, but they chose this particular area. And what more important topic is there than professionalism and ethics in the profession of medicine and in healthcare? And it is a great time for us to step back from the day-to-day trials and tribulations and think about some of the reasons that we're in this profession. So thank you again to the Berkowitz Foundation. I want to thank Susan and the Cooper Foundation for all their help and support in this. This is a great partnership, and this has been a great series for us. And we had Dr. Art Kaplan the first year, Dr. Danielle Ofrey second year, and now we have Dr. Lerner with us. So this great tradition continues. I also want to thank Dr. Ed Viner for reaching out and contacting Dr. Lerner and arranging so Dr. Lerner could spend some time with us. So without further ado, let me just say a couple words about Baron. Dr. Lerner is professor of medicine in the Division of General Internal Medicine and Medical Humanities at NYU Langone Medical Center. A very distinguished medical center that's gone through an awful lot of trials and tribulations of their own in recent years, not the least of which was Hurricane Sandy. Dr. Lerner received his MD degree from Columbia University and a PhD in history from the University of Washington. He has had a distinguished career focusing on medical ethics and the history of medicine. He's written a number of books: Breast Cancer Wars, One for the Road, story about drunk driving since last century, a book about tuberculosis and indigent populations. In his last book, the most recent book is The Good Doctor, A Father, a Son, and the Evolution of Medical Ethics, which is the story of two physicians. And I really am very pleased, Baron, that you were able to join us today, and thank you for taking time to be with us.
Good afternoon. I will join the thank you parade because there really are a lot of thanks to be said, not only to the Cooper Foundation and Dean Katz and Dr. Viner, who helped invite me, but particularly the Berkowitz family, and just learning a little bit about Ed and Barbara. It truly impresses me how patients could have the vision to set lectures up like this. I've done other lectures like this that have been set up by physicians, which are wonderful too, and to try to re-inculcate these values. But for patients, people who are not in the medical system, to have the vision that this is a way to educate the doctors of the future is particularly impressive. So I just wanted to mention that and also say hi to Ed and Barbara via our technology today. So I know some of you have read the book and some of you haven't. So what I'm going to do today is draw a lot on the book and talk about some of the stories about the two doctors. Some of you may not have figured out who the two doctors are yet. So that is my dad up at the top left, and that's me with a lot more hair at the top right. So we are the two doctors in two generations that I will be talking about. And that's the book that this comes out of, that many of you have gotten, and I'm so thrilled that that was part of the event today to get this. And my dad would certainly once he heard that medical students were getting this book, he would have been extremely happy about that. Okay, so let me outline where I'm going to go with the talk today. So I'll start talking about my dad and my family and our background. I'll move then into my dad's medical training and what I'll call his philosophy of medicine. About halfway, I'll shift gears halfway through and talk about my background in not only medicine, but studying history and bioethics. Toward the end, I'm going to present very quickly 5 cases from my dad's career that I think will demonstrate the type of physician that he was. And then I'll have some concluding remarks. Where does this lead us in the future, and what can we learn from my dad's story? How did I write the book? Well, I was very lucky. Probably the best thing in the world for a historian is a big bunch of documents that no one's ever looked at, and that was sitting in my parents' house. So my dad kept copious journals. The one at the top right there is the very first one he started writing, and when I was 1, he would write a note to me every year on my birthday saying, this is what went on in the family this year, this is what went on in the hospital. When my sister was born a few years later, he would write a note to her, so there was basically sort of 2 notes a year, but he got the writing bug, and by the mid-'70s, when I was a teenager, he was writing sort of all the time. Very often we'd grab a legal pad that was sitting around and start writing. The one at the bottom, it's hard for you to read, but at the top it says 3 a.m. He was a noted insomniac and would really write at any time. But what this gave me was an incredibly rich treasure trove of his reflections, both as my parent and as a doctor. I also looked at my own diary, which was compared to my dad's, which was like this, mine was like this. I was one of those people who thought that during 3rd year of medical school he would write a book about his experiences, and I was going to keep all these notes during all my rotations. I made it through about 1.5 rotations, and I totally sputtered out. But I did go back and reread what I'd come up with. I reviewed the relevant historical and medical literature from the late 20th century, which is the main era I'm going to be talking about. And I did some selective interviewing with folks who knew my dad, who worked with him, who had trained with him over the years, and I got some good stories, which I'll be sharing as we go along. So who was my dad? He was born in Cleveland in 1932 into an Orthodox Jewish home. And I wrote here he was the ambitious child of immigrants. So if you look at the top right picture, that's my dad graduating medical school all the way at the right. That's my uncle, 4 years younger than my dad, graduating college that same day. And in the picture, those are their grandparents, my great-grandparents, who moved from Poland to the United States right before World War I. They had already begun to experience some anti-Semitism, and they genuinely came basically with the clothes on their back and knew a relative in the United States and said, we need to go and leave Europe and move to the United States. And my dad kept reflecting on that story over and over as he embarked on his career as a doctor, and over in his journal said a big part of the reason he became a doctor was to pay back his relatives for being so heroic and giving so much to him. A perfect example was his father, my grandfather, who's the second from the left in the bottom picture. That was my grandpa Meyer, who had to drop out of school at age 12. Apparently was a very good student, had to start working, and he became a furrier. So when my dad entered med school in 1955, he was not only the first doctor anywhere in the family, but the first professional. Everyone else had been working class. And again, his career in medicine was very much as a way for him to give back to others. This notion only increased when he met some relatives in the late 1940s who had managed to survive the concentration camps in Europe and had come to the United States, and this only underscored for my father how lucky he had been and our whole family had been that my great-grandparents had, as he wrote it, narrowly avoided the Holocaust. So as you'll see, all of these factors played together and made medicine very much a calling for him. My dad went to Western Reserve School of Medicine. You probably figured out that now is Case Western Reserve School of Medicine in Cleveland. And Case, there was very good timing for my dad to be at Western Reserve. They were really in the forefront of humanistic medical education even in the 1950s. So I just heard at lunch today that students here sort of get their own crop of patients in clinic right when they get here and follow and stay with the patients. That's great, and that's the exact sort of intervention that I think is terrific, and it's great to hear. This is something that Western Reserve had the idea to do in the 1950s. When the medical students started there, they actually would get assigned a pregnant woman as their patient, and they would go to her clinic visits, they would do house calls, they would attend the birth, and then they would come into their preceptor groups and discuss this. This was their patient. And again, this was an idea of sort of putting the patient front and center as medicine was perhaps becoming, even in the 1950s, too technological. After med school, my dad moved on to Boston, where he did a residency in internal medicine at Beth Israel. Then he did a fellowship in infectious diseases with a doctor named Louis Weinstein in the early 1960s. I'll say more about Dr. Weinstein in a minute. But it's worth noting that this was an incredibly exciting time to be in medicine, and particularly the field of ID. Many have called the 50s and 60s the golden age of medicine. For the first time, really, in the 1930s and 40s, there were antibiotics to treat severe bacterial infections like pneumonia, endocarditis, tuberculosis. These were diseases that routinely killed prior to this, but by the 1940s, there was penicillin, there was streptomycin, and doctors were able to cure people in remarkable new ways. They were also able to prevent diseases, particularly infectious diseases. And here we would think of the polio vaccine, a picture of this being given in the 1950s, that basically eradicated the dreaded summer plague in this country by the 1960s and 70s. And the point was that this was incredibly exciting time for my dad and his peers to be in medicine. And it was also a good time for my dad to learn infectious diseases. Dr. Weinstein, who I mentioned before, was the head of a hospital outside of Boston, which was an old-type isolation hospital. So in those days, people who had various infectious diseases like TB and polio and whooping cough and diphtheria would get sent out to hospitals where they would be put so they wouldn't infect other people. And Weinstein was the head of this institution, brought his fellows out there, and as a result, my dad saw a remarkable amount of infectious diseases that were disappearing. So his clinical knowledge in his years as a fellow grew exponentially. Here's a picture of Weinstein. Here's a quote that my dad wrote about Weinstein and why Weinstein was such an important mentor to him. That's my dad in the back with the arrow. My dad wrote of Weinstein, "I found by an incredible stroke of good fortune the proper niche for my medical talents and teaching research instincts by falling under the spell of a mesmerizing, dynamic teacher who is fanatic, encyclopedic, opinionated, scholarly, and demanding of his specialty and all those who aspire to it or intersect its vast boundaries." So that's very flowery language showing the intensity of Weinstein and when my dad found that to be so important to him. As you might imagine, these words could very much characterize my father's type of medicine as well. A bit more about doctors from this era and what we might call sort of medical family trees. Historians of medicine like myself often like to trace back doctors over the generations to see which doctor trained which doctor, to see why those people became the physicians that they did. And it's very easy to do in my father's case. I mentioned Weinstein as my dad's mentor. Weinstein's mentor was a doctor named Chester Kiefer at the Boston City Hospital. Kiefer, in turn, had trained with Paul Beeson, a well-known infectious disease doctor who was the dean of Yale Medical School. Beeson had been a student and an intern at Harvard under Soma Weiss. Some of you have heard of the Mallory-Weiss tear. And if you go back 2 more generations, you get to the famous William Osler, the very well-known turn-of-the-century doctor, both at Penn and Johns Hopkins and later Oxford, who epitomized really the doctor humanist of this medical era. So what were these doctors like? Well, for one thing, they were all great diagnosticians. You might think of this era of medicine and seen pictures from this time, and you might have seen an image of 20 doctors standing by a patient's bedside, and the head doctor is at front examining the patient, and then the residents are behind the doctor, and the medical students, and then the nurses sort of obediently in the back. And the story goes that this doctor would be brought to the bedside of a patient and no one could figure out what was going on. And this doctor would take a history and examine the patient and say, aha, this patient has such and such, something no one had ever thought of. And everyone would go, oh my gosh, he's right. And now these stories were somewhat apocryphal, right? These doctors didn't always get the diagnosis right, but they often did because their knowledge of medicine and their devotion to medicine was paramount. Perhaps even more important than their diagnostic ability was their humanism. Patients were the most important thing. Patients were not diseases. We were taking care of our patients front and center. Patients were put on a pedestal. I like to tell the story of a doctor named Robert Lerb, who was for many years at Columbia in New York and the head of the Department of Medicine there. Lerb did not understand the concept of being on call or being on service. He basically was at the hospital 7 days a week, regardless. Would come in on Sundays, any days on the weekends, just make rounds himself on his patients, on other people's patients. And he prided himself on knowing the patients' names, the names of all the family members, the names of everyone who worked in the hospital. And it was said he also could tell you the previous time the patient had been hospitalized, what room they had been in, who their nurse was, and who their intern was. So again, I don't know if that's necessarily true, but I think it conveys this idea that doctors at this time had of the devotion they needed to show their patients. At the bottom of the slide, I put rarely took no for an answer. Some of these guys had pretty darn big egos, weren't necessarily interested in whether or not you agreed with them, but were just interested in telling you that they were right. So a challenging group at times. So back to my dad. By all accounts, from what I learned from his journals and from the folks I spoke to, he was what we would call a master clinician. In his heyday, he read 12 journals cover to cover. That would be ID journals and more general medicine journals like Lancet, New England Journal, back to back, would read all of the articles, would pull the articles, some of the ones that were most relevant, out of the journals, especially the ones that had to do with ID and diseases, create these folders of a particular infection. And when he had a patient who was admitted with this infection, he had like a knowledge base of all these articles he'd read and underlined that he could go back to. And in that sense, he was willing, when he treated patients, to use both his own knowledge of clinical medicine and these sort of retrospective studies that he had read about in medical journals to help guide patient care. That isn't to say that he didn't know the latest randomized controlled trials and the best scientific medicine, but he also trusted his judgment. And one of the 5 cases I'm going to tell you about later demonstrates this. More important, perhaps, than his diagnostic ability was how he knew his patients as people. I put down here Jewish and non-Jewish patients. After my dad completed his training in Boston, he stayed on for a couple years as a professor at Tufts, and then, much to my mother's chagrin, moved from Boston to Cleveland, where he took a job first at the VA and then at the Mount Sinai Hospital in Cleveland, which was an affiliate of Case Western Reserve. One of these hospitals founded by Jewish philanthropists to treat predominantly Jewish patients in the early 20th century. But by the 1970s, when my dad got back there, the neighborhood around Mount Sinai had changed. It was actually predominantly African American, and Mount Sinai was an interesting mix. It was about half Jewish patients and half African American patients, and my dad, over and over in his writing, said, I give the same devoted attention to all my patients regardless of who they are. He liked to do what he called afternoon revisits. In the middle of the day, he would go back to the hospital to see his inpatients. Sometimes it was just to sit on the edge of the bed and talk to them. Sometimes it was to update them about what was going on. And my dad was able to do this in part because he had a pretty flexible practice. He was a consultant, an ID consultant, so he didn't have a large private patient population himself. He was called in by other doctors to see patients. So in the afternoons, he did have time, extra time to spend with his patients. He liked to go to his patients' x-rays and operations when it was possible. So he often would scrub into the OR if one of his patients was having a major surgical procedure to provide support and knowledge to his patients. He also would go down to the radiology department when his patients were getting major x-rays done. So when I was beginning to research the book, I knew he was doing this, and I said to him, so, why was it you took the time out to go to the radiology department? And he said, sometimes my patients would be getting a CAT scan, they'd be getting an ultrasound, we might be making a major diagnosis here, and I thought it was good for me to be there when they got the news and sometimes be able to deliver the news to them myself. And I said, all right, that seems consistent with his medical philosophy. So one day I was with my uncle, remember him? Graduated 4 years younger than my dad. So my uncle went to Western Reserve Medical School as well, and he became a radiologist, and he worked at Mount Sinai also. So one day I was talking to my uncle, and I was like, I was talking about my dad always being down in the radiology department, and I asked him why, and he said, he liked to be there to support his patients when they got a major diagnosis. And my uncle, he started shaking his head and then used an expletive, which I'll spare you from, but basically said, that's total bull. Your dad came down to the radiology suite because he didn't trust any of the radiologists to read the x-rays, including me. So. And I also learned from my dad's journals why it was we didn't go on vacation until the end of the month. So when I was growing up, we either went away the end of June, the end of July, or the end of August. Never early in the month. I assume that's when people went on vacation, but I read in the journals that the reason that was the case is that the teams would switch at the beginning of the month. So there'd be a new attending, my dad, new fellow, new residents, new medical students, and he didn't feel comfortable leaving the city, leaving the hospital, unless there'd been a couple weeks where the team had gotten to know the patients. Now, having said that, he was on the phone with his fellow while we were on vacation the whole time anyway. So if you're the sort of person who is this devoted to medicine and his patients, you might expect that he would have held his colleagues to a very high standard as well, and my father did. And as a result, he was very willing at times to criticize his colleagues, often openly, often in public in the hospital. Now, he never did it because they made an honest error, but he would do it if he felt that they were cutting corners and not devoting as much to their patients as they should be. About 10 or 12 people that I interviewed told me this same story when I was trying to get anecdotes about my dad. They were like, oh my God, I can totally see your father standing at the nurse's station, pounding on the nurse's station like this. And I'd be like, what was he doing? And he'd be screaming, give the antibiotics now, give the antibiotics now. And so it turns out patients who probably had sepsis, a bacterial infection of the blood, needed to get the antibiotics fast. And my dad was nervous that once they got up on the floors, there'd be some kind of problem and the patient wouldn't get the antibiotics fast enough. So he would stand at the nurse's station pounding his fist until the nurse actually gave the antibiotics, and he would go away. So this sort of behavior earned him the informal nickname of the madman of the Mount Sinai, which once I believe he learned it, he actually wore it as a badge of honor. But the important point was that my dad believed that his vast knowledge of medicine, combined with his intensive approach to his patients, made it his duty to make decisions for them. So if you knew all the medicine and you spent this much time with your patients, why would you then go to your patients and say, here are 4 options, what do you want us to do? It didn't make any sense for him. So in that sense, my dad was an unabashed paternalist, right? He heard a phrase, doctor knows best. When I hear that, I'm like, I don't know. Sometimes I guess, sometimes maybe not. I'm uncomfortable with it. He didn't mind it at all. He's like a doctor who devotes his or her time to their patients, does know best. As a result, like many doctors in the 50s and 60s in particular, he was more than willing at times to withhold information from patients. So when I was reading his case books, sometimes he would write, told patient one thing, told family member another thing, do not tell so-and-so something. And it was crazy how he kept it straight, I don't even know. But the reason he did it was to get the patient to take the course of treatment that he thought was best. And that's why he was willing to manipulate the information. He did another ethically dicey thing that I talk about a lot in the book, those of you who've read it. He took care of a lot of my family members. So particularly as my relatives were getting older, both of my grandmothers were getting very infirm, he basically started to become their doctor and pushed the other doctors out of the way. And I'm not going to go into all the details in this talk about what he did, but he did some ethical things that were questionable. But for the purposes of this talk, the reason he did it was because he was a paternalist. He thought to himself, I'm a doctor who knows the medicine, and I know these women, his mother and mother-in-law, for decades. I know what they want and what they don't want. I'm the one who should be in charge here. Again, that same philosophy of paternalism. And this quote, I think, from him sums up his philosophy. Patients trapped in a desperate situation need a firm but concerned individual to take charge of their health-related problems. So there it is. Okay, back to me. All right, I grew up not in a working class home, but an upper middle class home in the suburbs of Cleveland. I was a non-observant Jew. My dad pretty much had turned on his Orthodox upbringing after his bar mitzvah. I had loved history in high school, so history was always my favorite course. And indeed, when I went to college not too far from here at Penn, I was a history major, even though the pre-med advisor there, who I met with, I don't know, a couple weeks into freshman year, was like, no, don't do that, it's a bad idea, you'll look like a dilettante. I still remember that. And I said, look, don't worry, I'll take all the pre-med classes, I'll try to do my best, but I really want to do history, and I sort of stuck to my guns, and of course these days it's a smart strategy to get into medical school. But the big break I had for my career, actually the first of two, was when I got to medical school at Columbia. So in the early 1980s, everybody was talking about this new thing called bioethics, right? And I'll talk about the content of that in a minute. But medical schools in the early 80s started to say, we need to begin to teach our medical students about bioethics and doing right and wrong in medicine. And at Columbia, the person that they hired to teach bioethics was a historian who was a professor at the Morningside campus of Columbia, who came up to the medical school at 168th Street, named David Rothman, who taught the first class on bioethics at Columbia Medical School. He came up the exact same year to teach this class that I was a first-year medical student, so I was among his first students. Now, he called the class Society in Medicine, but basically it was a class on bioethics. What were we learning about in this class? Well, Rothman was a historian, and he grounded his discussion of bioethics in larger social changes going on in this country at that time. So think about the 60s and 70s. You have the civil rights movement, you have feminism, second wave feminism, you have the Vietnam War protests, all of which demonstrated ways in which authority figures in the United States were being called into question for the first time. And what bioethics was about was the medical profession being called into question. And I showed you before that sort of golden age of medicine when doctors were making all these new discoveries and they were sort of the king of the hill and revered. All of a sudden, there were all these stories coming out about things that doctors were doing that seemed not so ethical. Right? So let me remind you of some of them. These are the things we studied in my course with Rothman. One of the things we studied was the Tuskegee Scandal, which you all undoubtedly know about, in which poor African-American men from the South were deliberately left untreated for syphilis for up to 40 years by doctors working for the U.S. Public Health Service, who seemed to be violating the notion of do no harm. We learned about the Willowbrook Scandal up in New York, in which professors from NYU, my current institution, were actively injecting hepatitis virus into mentally disabled children at a huge institution on Staten Island to study the history of hepatitis. Wow. We learned about the Karen Ann Quinlan case, in which a young woman had some type of overdose of alcohol and drugs and went into what we would now call a persistent vegetative state. After time period, the family said to the doctors, she wouldn't have wanted to live like this, we want you to take her off the ventilator. Doctors said, no, you can't do that. We won't take her off the ventilator. Case eventually goes to the New Jersey Supreme Court, and ruling is in favor of the parents. And Karen Ann Quinlan was extubated, although she wound up living for several more years. We learned about the baby doe cases, of which there were several around the country, which informed the public that it was entirely common when severely disabled neonates were born for doctors to independently put the babies aside in the nursery and let them die and not do curative surgery, and did this pretty much by their own judgment. And parents were learning that this was happening and questioning how it was that doctors were, in essence, playing God. So what all of these scandals and others indicated was a curious development in which doctors, previously revered, were now doing these things again that seemed unethical. Unethical research, not listening to patients, playing God, and that sort of thing. As a medical student, particularly interested in history, I loved this course. Not every kid in my class liked the course. Some thought Rothman was a doctor basher. But I loved it. I found it fascinating understanding the historical progression and why bioethics had come to be taught as it was. Now, I went on to become an internist, did my training in internal medicine, and then I got, I guess, what was my second break, which was through the Robert Wood Johnson Foundation. I was able to go out to Seattle, where I was a fellow for 2 years and eventually was able to go on and get a PhD degree in history and a degree in ethics as well through this program. And when it came time for me to pick a dissertation topic, I wanted to do something about medicine, about history, and about ethics, because those were my interests. And someone out in Seattle said to me, I have the perfect topic for you. Did you know that during the 50s and 60s, thousands and thousands of mostly men, mostly alcoholics in Seattle were forcibly detained against their will at a tuberculosis sanatorium here? And I said, I didn't know that. But that sounds interesting, right up my alley. Did some research, actually got into the patient charts, and found out it was entirely true. I believe that more patients, TB patients, were detained in Seattle than everywhere in the country combined. And when I studied this, I found some interesting things. It turns out that the health department had put a locked ward in the sanatorium only to be used for patients who were already under quarantine with TB, infectious TB, who violated their quarantine and went out of the sanatorium in an infectious state and were potential public health risks. They could be put in the locked ward. But over time, the doctors at the sanatorium began using the locked ward for other reasons as well. So if someone, a lot of these guys, as I said, were Skid Row alcoholics, if they got caught drinking on the premises, the doctors would put them in the locked ward. If they went AWOL from the sanatorium and had to be brought back, even if they weren't infectious anymore, doctors put them on the locked ward. So basically, the doctors were acting like policemen in their own institution. And I asked the question in my dissertation, then what became my first book, how was it that doctors who were trained to be medical people and do no harm had basically become police? My second book was on breast cancer, and a big topic in that book was the early 1970s, when women, for the first time, started to go to their doctors and said, I don't want the big, large Halsted radical mastectomy for my breast cancer. So up until the 1970s, the same operation for breast cancer that was pioneered by William Halsted at Johns Hopkins in the 1890s was still being done. When Halsted saw breast cancers in that earlier era, they were often this big, and he came up with this operation that would encompass the entire cancer. So the woman would lose her breast, the underarm lymph nodes, and both chest wall muscles, because that was the only way he thought he could potentially cure these large cancers. But the operation was extremely deforming. By the 1970s, women were coming in with tinier breast cancers that were discovered on palpation or mammography, and the doctors were still doing the Halsted radical because that's what they'd been trained to do by their mentors and their mentors. And a few doctors had begun to question this and told women, if you have a lump, you should go to your surgeon and discuss options with them. You may not need a Halsted radical. Maybe you just need the breast removed. Maybe you just need a lumpectomy. You should talk to your doctors and make an informed choice. Well, when many of these women came to their breast surgeons, they were treated in an utterly derisive manner. Ridiculed, treated with condescension. How dare you tell me what to do? I'm the doctor. And really treated almost acting with arrogance. And so, again, I said, how was it that this generation of my doctors, that was my dad's generation that I grew up revering, how was it that they were behaving like this with their patients, with their breast cancer patients, much like their TB patients? So as I did further and further studies, I became a passionate advocate for what we would call patients' rights, patient autonomy. The exact opposite philosophy of my dad, who was a paternalist and said, doctor knows best. I said, you know what? We tried that era, and there are too many problems with that. The job of the doctors is to empower patients to make these decisions. Because the era of paternalism, there were too many things going on that were not right. So a perfect example of this was the whole issue of death and dying. And when I was training in New York in the late 1980s, the first DNR law, Do Not Resuscitate law, was passed in, I believe it was 1987 in New York, which said patients and families get to decide whether or not resuscitation will occur. Before that, again, doctors quietly made the decision themselves for patients in the hospital. We are going to resuscitate, we're not going to resuscitate. The media found out about this, patients got mad about it, and the law was passed saying, you know what, doctors, you can't do that. You have to go talk to your patients and get them to decide about resuscitation. And I remember the senior doctors at Columbia at the time were horrified by this. They were like, how can we expect patients to make these difficult life and death decisions when they're in the hospital? We need to make these decisions for them. And I pushed back and I said, you know what? The times have changed. That era is over, and now it's time, like it or not, for patients and families to be in charge. So there was that great dichotomy. Okay, so I'm going to shift quickly to my 5 cases that I'm going to tell you very briefly, and then I'll have some concluding remarks, and I think we'll have a little bit of time for Q&A. So I'll go through these pretty quickly. But again, these are 5 of the many cases that my dad took care of that I think will demonstrate the various aspects of his medical career. Case number 1, this was an elderly woman at Mount Sinai, I believe she was in her late 70s, who had a fever and a cough for several weeks, a productive cough. She'd already seen several doctors, she'd gotten some antibiotics already, and she wasn't getting better. They eventually brought her to Mount Sinai Hospital for more tests. This patient, turns out, was a devout Orthodox Jewish woman, and even though my dad was no longer Orthodox, he had a great deal of experience at Mount Sinai dealing with Orthodox Jewish patients. And so when all the tests came back negative, he went to the patient and said, there's only one other thing we can do. Unfortunately, we have to do an operation called an open lung biopsy. So we're going to have to cut out a piece of your rib cage and go in and get some tissue to figure out what's going on here. And he explained to the patient as best he could about that, but the patient wanted nothing of that. She told my dad, I'm sorry, I'm too old for surgery. I do whatever else you have to, but I won't have an operation. And again, my dad pushed back. He said, I understand, we never do unnecessary surgery, but you're otherwise very, very healthy. We should go ahead and please let us do this operation, but the patient wouldn't change her mind. So they were really stuck. They didn't know what to do. She wasn't getting better. So my dad had an idea at that point. He said, ask the patient, would it be okay if I called another infectious disease specialist from Cleveland to come over and see you? The patient says, fine. So my dad calls his buddy, Marty McHenry, from the Cleveland Clinic. McHenry, it turns out, was a very devoted Catholic. He had grown up in a Catholic household and also remained a devout Catholic his entire life. He went to see the patient, he took a history, he examined her, he looked at the x-rays, finally comes back, says, Mrs. So-and-so, thank you for letting me see you. I must tell you that I agree 100% with Dr. Lerner. There's just absolutely nothing else we can do here except an open lung biopsy. Patient says, thank you, Dr. McHenry, I appreciate it. But as I told Dr. Lerner, I don't want to have surgery. McHenry shrugged his shoulders, said, okay, I understand, started to leave the room, and then had a thought and turned back and said to the patient, one more question, would it be okay if I prayed for you? And apparently there was silence in the room, and the patient said, that would be fine. So McHenry, who always had his rosary and his long white coat, pulled out his rosary, knelt down and started praying, and as you can see, the patient had the surgery the next day. So I love that story. When people talk about the art of medicine, that's probably about as good an example as you can get. Case 2, very different type of case. This was a middle-aged woman my dad was seeing who had leukemia, chronic leukemia. She had it for about 9 years. She got infection after infection. She was immunocompromised. So my dad had a lot of interactions with her. And he wrote of this woman that he was always available, even for the most trivial of problems or questions. And I distinctly remember as a teenager that she called our house all the time. And the joke was she never called during dinner because she knew when we ate. But sure enough, at 8 o'clock when we were done, the phone would ring many nights. And it would be this patient, and she'd say, "Can I talk to your father?" And we'd give him the phone, and he'd talk to her for 10 minutes. And he also, I remember, talked to her on vacation. But it wasn't until I read my dad's journals that I understood exactly what the dynamic was there. So it turns out that this patient was having a very difficult time with her disease. I think some patients get sick, and they sort of go with the flow, and they're very stoic. This woman was very angry and frustrated. Why me? Why do I have to get all these tests? And my dad realized at some point that if he could be there for her and let her vent about her frustration and anger, she actually would do pretty much anything the doctor said and would probably live longer as a result and be more compliant. So my dad wrote of her, "She screams and carries on when the going gets tough, knowing that I understand and will never reproach her, never abandon her, whatever." And he never did. Case number 3. This was the case I alluded to before where my dad went off-label. Not this patient, but the patient would have looked a lot like this. An elderly woman with ophthalmic shingles. Basically shingles involving the eye, very serious disease where you can lose your vision. And this patient came in the hospital and they gave her the treatment that had been approved in a randomized trial by the NIH, which was acyclovir, an antiviral drug to treat basically herpes zoster of the eye. This patient didn't get better, though. But there was some anecdotal information, never proven, that an anti-leukemia drug called RSC was effective against shingles of the eye. And when I was doing my research, I found the article my dad used when he treated this patient. It was a retrospective study of 7 patients who got RSC for shingles. So my dad went to this patient and said, "You didn't get better with a standard treatment. We want to try this drug RSC on you, although there's no scientific proof it works. Some of us have anecdotally seen that it works. Could we try?" And the patient said, "Yes, I trust you, Dr. Lerner, you can try it." And she quickly got better. Now, I can't prove to you it was due to the RSC, but I like these quotes that my dad gave after he treated her. He wrote, "This was a beautiful demonstration of the value of a specialist in a given situation, and this is really a minutia type of therapeutic maneuver and can only come about through word of mouth and personal experience." And especially for the old timers in the room here, I like this quote because it really harkens back to an earlier era of medicine again, in which medical judgment and what you'd seen as a doctor played a very more major role than it does today in how you prescribe medications. Case number 4, this was a man that my dad saw in the late 1980s in Cleveland who had AIDS. Again, I don't have time to say a lot about AIDS in this era, except it was incurable and fatal. And what ID doctors did at this time was they put their patients on a complicated regimen of AZT and vitamins and some other antibiotics to try to keep them alive for as long as possible. And indeed, this patient, by the time my dad met him, had end-stage AIDS, almost no T cells, but my dad managed to keep him out of the hospital for 2.5 years. But during that time, the man's liver and spleen were getting larger and larger and larger. My dad suspected he was developing what was very common at the time, an AIDS-related lymphoma. Eventually, his spleen got so large that pain pills that he was being given at home weren't working anymore, and they knew they had to admit him to the hospital. This was, therefore, a fork in the road. There were 2 choices, really, that could have been made. One would have been to say, okay, why don't we try to do a biopsy of this man's liver or one of his lymph nodes, see what this lymphoma or whatever is, and try to treat him with some chemotherapy. Or we could say, you know what, why don't we just make this man comfortable and give him better pain medication? My dad chose the latter. He wrote of this patient, quote, "Chemotherapy would be too hard for him to tolerate." He did not ask the patient the question at all. He made that decision and wrote that. And when the patient came in the hospital, he wrote orders for a morphine drip, that this patient was to get aggressive pain control. He was sent to the ICU to get this treatment. Now, how did my dad justify doing this? And this was 1989. This wasn't 1969. How did he justify making all these decisions himself? He wrote of this patient that he and the patient had had a tacit understanding. And I warn all the clinicians here, please don't write that phrase in any medical charts anymore. Okay, what did he mean by tacit understanding? So as the patient was developing this presumed lymphoma, my dad had not ignored it, he'd mentioned it. He said, you know what, your liver and spleen are getting larger. It could be lymphoma. Every time he mentioned that to the patient didn't want to hear about it, the patient changed the topic. And my father took this to mean that the patient was giving him a few times a day, sit down at the bedside, take his hand, talk to him. And after one of those visits, my dad wrote, he squeezed my hand in return as he smiled at me, thanking me, I think, for being so concerned about him. Now, my dad was not without insight into the dramatic nature of what he had done. He wrote of this case, I admit this is medical paternalism at its very extreme. He was wrong. Case number 5 is. That's a teaser. Okay. He also wrote the following. I know what I did was right because all of my colleagues who helped me care for him, and there were many, were equally relieved that his suffering was over and the end came swiftly and peacefully. And this is a great quote because this again harkens back to that earlier time when doctors and nurses knew when someone was dying, and they looked at each other and they said, now it's our duty to make this person comfortable and give them the best death possible. And this was becoming almost impossible to do in the hospital anymore because patients and families had become the decision makers. Case number 5. This was a woman hospitalized at Mount Sinai in 1996, less than 20 years ago, who had very bad end-stage rheumatoid arthritis. I don't think I've ever seen a case nearly this bad as it was described to me. Basically, none of the anti-inflammatory medications for arthritis were working, so all of her joints were massively swollen and massively deformed, and she was basically constricted. Her joints were so inflamed and disabled. As a result, she'd been bedbound for 3 years, had only been out of bed when they would take her out of bed and put her in a wheelchair to go to the doctor or to sit up during the day. But she couldn't move by herself at all, in bed all the time. She'd been in Mount Sinai for this hospitalization for 3 months. Why was she in Mount Sinai? At home, she'd gotten an infection through her skin. Because she was so sick, couldn't eat, the protein in her body was very low. She was malnourished, so she was completely edematous, and her skin was completely broken down. So she had no way to guard against infection. So the best you could do would see this woman, treat her for one infection, but know that 2 or 3 days later, she was going to have another infection. And my dad was the one who was called in to treat infection after infection, and she'd been there for 3 months. Her day-to-day existence was agony. My dad wrote about her. Every time this woman moved or was even touched, the raw denuded skin would be further abraded, bleed, and give her agonizing pain as the sheets of dressings were pulled away. So a terrible existence and getting worse with each infection. Never going to leave the hospital. This patient was not do not resuscitate. I don't know why. My dad, again, was not the primary doctor. He was only the consultant. But this patient was not DNR. And maybe it's because she had rheumatoid arthritis and they were saying that's not a terminal disease. I don't know. One morning on rounds, the team, my dad, the infectious disease team, came into the room to see the patient. And she had just died. How do we know? She had no pulse. She wasn't breathing. She was not responsive, but her skin was warm. So she had died probably moments before the team got in the room. The team was there, there was a nurse there, and one of the medical residents, and that's when my dad said, do not run a code on this patient. It's thoroughly inappropriate, don't you dare run a code on her. And my guess is it probably was a little eye rolling, but everyone said okay. And then my dad and the ID team went down the hallway where they had another ID patient to go visit. But a few seconds after they got there, they hear an overhead page. Code red, and the name of the floor, and my dad realized someone had gotten cold feet and decided to call a code. So my dad and the ID team rushed back to the patient's room, and indeed, the resuscitation, the code team is assembling there and starting to do all the things you do in a code, which is to put IVs in and breathe for the patient and compress her chest. That's when my dad did something extraordinary. He put his body on top of the patient. I'm pretty small and skinny. My dad was big and strong, and when he put his body there, it would have been very hard to push him away. And the team sort of tried to do things, but they clearly were unable to do anything, and after a few minutes, they decided to stop, and the patient was officially declared dead. Now, one of the fun things, challenging things, interesting things about writing the book and reading my dad's journals was that sometimes, not only would he have a case like this and write about it in his journals, but he would call me on the phone or talk to me about it and then write down what I said about the case at the time. So that was the best thing you could expect. And this was one of those cases, right? So he recorded what I said to him when he told me about the case. And he wrote that I had been aghast and said to him, "You can't do that." And I also remember saying to him, because I was sitting on an ethics committee at Columbia at the time, I said, if you had tried to do that at Columbia, you would have been called in front of the ethics committee, the hospital executive committee, I don't even know. It didn't happen to my dad at his hospital. But my dad pushed back and said, no, what he had done was correct and merciful, and wrote the following: I acted in the name of common, ordinary humanity and based on my 30-plus years as a physician responsible for caring for and relieving the pain of my patients who can't be cured. Okay, a few concluding remarks. Do not take away from this lecture the idea that I am suggesting we reverse medicine back to my dad's era. There's no going back. Informed consent and autonomy are here to stay, and I think that's a very good thing. That whole business where my dad was concealing things and telling certain people one thing another, not good, inappropriate. There's also lots of other barriers to this sort of practice of medicine that my dad did. The biggest one is time. I told you how my dad had a lot of time to spend with his patients, and today it's much harder. As a primary care doctor, I get 20 minutes per visit with patients at max to see them. As residents in the hospital, you're now kicked out of the hospital if you've worked too long, if you've worked 24 hours in a row or 80 hours over a week. You get pushed out. So even if your patient's sick and you want to stay, you aren't allowed to stay. You're told you have to have a life outside of medicine. My dad didn't have much of a life outside of medicine, but today you have to. We also have hospitalists today, right? So I'm a primary care doctor. If I want to follow my patients in the hospital and be in charge of them when they're in the hospital, I'm not allowed to do it. The patient is turned over to a hospitalist, and by the way, multiple hospitalists during their stay. So the notion of a doctor being a continuous doctor for a patient is gone. Having said that, though, I think there are aspects of my dad's career that we can try to continue in modern medicine. And take advantage of some of these changes. So for one thing, go out of the hospital and actually get some sleep. So my dad, as I said, was in the hospital all the time. He and his colleagues, and certainly when I was training as a house officer, everybody was asleep all the time at meetings like this. It was crazy, but you couldn't get too mad as a speaker because you knew when you were back in the audience, you would be sleeping also. But it was a crazy way to learn things. Everyone was tired all the time. So actually getting out of the hospital, refreshing yourself, do your medical reading when you're outside, do other kinds of reading, but it's a good way to be, not the way it was. I can visit my inpatients. Just because I'm not in charge of them when they're in the hospital doesn't mean I can't go by, see the patients, take a look at what's going on in their charts, and give some helpful suggestions, although some of the hospitalists might say they weren't so helpful. I can pick up on patient distress. This doesn't take very long. Right? Another story people told me over and over about my dad, they'd be on ID rounds in the hospital, making rounds, and they'd hear a disturbance somewhere in the wards. It wasn't an ID patient, it wasn't someone they were following, but a patient would be crying, somebody would be having an argument. My dad would say to the ID team, let's go, and they'd walk into the patient's room, my dad with his long white coat and all the other doctors, and he would just say, hi, I'm Dr. Lerner, this is my team, what's going on and how can I help? And he didn't stay for more than 2 to 5 minutes, but it was an important gesture. And I think my dad would have been comfortable As I said, he was on the phone with his patients. I think he would have been comfortable with using the new technologies to keep in touch with patients, whether texting, emails, Skyping, whatever it is. Medicine has changed, but I think the important thing for him is being in touch. Most importantly, try to get to know who your patients are, and it's a lot harder now. But even if it's only for a few minutes at a time, what I try to do in my 20-minute blocks with my patients, I have a rule. I say, you know what? You got 15 minutes to talk about your medical problems, and I got 5 minutes to talk to you about something else. And it doesn't always work. But when it does, it can. And I let them talk about whatever they want. Sometimes it's about where they're going on vacation, about their family members. Sometimes it's medical, people who are sick in their family. Sometimes it's about a medical TV show they saw, what they think about that. And in this way, if I can follow people over time, I get, even in this limited time environment, to learn a little bit about their wishes and values. So when the time comes to make difficult medical decisions, there's an established relationship. And what I hope I wouldn't have to do would feel the need to give them a menu of options, but be able, using my knowledge of them and my past interactions, to try to give them guidance as to not only getting them to make their decision, but to make perhaps what the best decision is. And my last slide, I think this is all especially relevant in a world of end-of-life care. As we all know, costs are way out of control, especially at the end of life. So much of the Medicare dollar is spent in the last 6 months of life for interventions that are not particularly effective and arguably do more harm than good. This was what my dad got focused on at the end of his career in infectious diseases, all these patients with infection after infection who were demented, who had cancer, who had feeding tubes, who were in nursing homes. Why were we doing such aggressive interventions? Well, part of the reason was he thought doctors had abdicated their responsibility to have meaningful discussions with patients like this because the patients and families were now in charge. So to the degree that our interactions with patients these days can raise some of these difficult issues early on, talk about them frankly, and give patients and families guidance for these difficult end-of-life decisions, I think it would make my dad very, very happy. So thank you so much for your attention. And again, thanks to the Cooper Foundation, the Berkowitz Foundation, for the opportunity to speak to you guys.
Thank you, Baron. We have time for a few questions. No one? Go ahead.
Wait, say it. I'm missing this. Your training in medical ethics, say it again.
My training in medical ethics was, Warren, don't sleep with your patients. When you sleep with your patients, they don't pay their bills. I've since gone on to get a master's degree in biomedical ethics at Kaplan.
Yes.
And I think that paternalism, you're right, that day is gone. But so frequently we see students, fellows, residents giving the patient the menu. Here we can do a biopsy, we can do this, and the patients are not, they don't have the knowledge to make a decision, and they're not comfortable. When I go to a doctor for a non-gynecologic problem, I want the doctor to say, this is what needs to be done. And I think we've gone too far with, I hate to say too far with autonomy, but too far with whatever you want is fine.
Yeah, no, I agree, and I'll just give you an example of that. I precept residents in clinic, and very often they will come to see me to go over a case, and they'll say to me, the patient asked me what I thought. Can I tell them? Because they've all taken medical ethics from people like me in medical school who tell them patient autonomy is key and informed consent, and they think now they can't ever give any advice. And I'm like, wait a minute, of course you can. That's fine. If they're asking you, that's how they're demonstrating their autonomy, that they want to hear what you think. But I do give the caveat to say, look, just because I'm the doctor doesn't mean you should do this. But this is my thoughts on the matter, and you shouldn't make this decision only based on this. But here are my reasons. And in that way, I think we can bring back some of our ability to give advice while still trying to respect the ultimate decision-making capacity of patients and families.
Dr. Feiner.
I think the only difference between
Yeah. Yeah, no, I think that that's true. And look, that was the insight of the bioethics movement, which is to say that, you know, doing things for other people didn't respect their rights. And again, that's why, you know, when I learned that course in medical school, this was all about, like, you know, civil rights and feminism, and it was like, you're in charge of your own body. And so doctors had to change, absolutely.
Any other questions or comments? I want to mention that Dr. Lerner will be spending some time with our first and second year students when Dr. McGeehan to talk more about some of these issues. And I too want to thank the Berkowitz family and Ed and Barbara, and thank you all for being with us today. And thanks to Susan and the foundation and to Ed Viner for bringing Dr. Lerner to us today. And Baron, thank you so much. Really terrific presentation. Thank you.